Thank you, everyone, for joining us on today's webinar. I'd like to thank the funders of Cochrane Canada, without whom these webinars, our training, systematic reviews, and capacity building could not happen. Thank you also to CIHR for their support. I'd also like to thank PAHO for kindly providing the software for our webinars. And a special thank you to Luis Gabriel Cuevo, who provides the videos to our webinars. Today's topic is an introduction to concepts in network meta-analysis, and we'll be hearing from Brian Hutton. He is an MSc in statistics and with a PhD in epidemiology and associate scientist at the Ottawa Research Institute's Knowledge Synthesis and Systematic Reviews program, led by Dr. David Moher. And he's an adjunct professor at the University of Ottawa Faculty of Epidemiology and Community Medicine. His research interests include systematic reviews, meta-analysis, network meta-analysis, statistical methods, clinical trial design. He's currently working on NMAs through funded projects by the Canadian Institutes of Health Research and the Drug Safety and Effectiveness Program. Without further ado, here's Brian.
Okay, thank you very much, William, and good afternoon, everyone. So as William mentioned, what I'm going to present to you over the next 50 minutes or so will be an introduction to the concepts, at least some of the concepts in network meta-analysis. Now we have a very broad audience for today. The last time I saw the registration list, we had about 560 registrants from more than 60 countries, which is wonderful. With such a broad audience also comes a very mixed level of exposure, both to network meta-analysis and also to traditional meta-analysis. So to try and cater to the broadest audience possible, what I have tried to do is take a very conceptual approach to today in terms of talking about what I call the what, the when, and the why for network meta-analysis in terms of what is it, when might we use it, and why might we use it. And what I try and do is motivate this introduction by the use of a lot of examples from the literature. And what I'm going to do as I discuss these examples is talk about some of the core methodologic considerations that one should think about when using network meta-analysis. Now we may also have folks who are intermediate to advanced users of network meta-analysis. Now I may not be addressing all of the needs of those folks today. What I have tried to do is provide detailed reading lists as appendices to these slides so that later on, when you come back to these slides, you may find topics you can go and look up the papers for that are of interest to you. And I'll certainly also always welcome questions via email. You can all see my address there, bhutton@ohri.ca. Now the outline I'm going to follow for today's session, which will take us about 50 minutes or so, and we should have a good 10 minutes or so at least for questions. I'm going to start out the first 5 minutes or so just providing a very brief overview or reminder for folks of just exactly what meta-analysis is. And I mean the traditional pairwise approach, because network meta-analysis is an extension of this technique. I mentioned I'll be taking a conceptual approach, so what you will not be seeing in today's session will be anything to do with a lot of Greek lettering to denote equations, no heavily mathematical formulae laden talks for you, slides for you to look at. So hopefully you'll find it to be an intuitive presentation. The topics that I plan to cover during this session, first of all, will be to talk just a little bit about how similar versus how different is network meta-analysis compared to our traditional pairwise approach. In what you'll hopefully find to be digestible terms, I'm going to talk a bit about how it works as well. And to motivate that discussion, I'm going to focus on an example from the literature. It'll be based on a paper from 2011 and published in the BMJ looking at treatments for generalized anxiety disorder, or GAD. Once we work through the example, I'll spend just a few slides talking a bit about some of the advantages and also the disadvantages that we gain by using a network meta-analytic approach in systematic reviews. I do want to spend just a moment or two showing you just exactly how commonly used this technique has become because of the need to look at multiple interventions in medical research. And talk a bit about, lastly, some of the underlying assumptions as well, namely homogeneity, similarity, and consistency, terms you may have heard. And I want to talk about them in terms of how we need to judge the validity of a network meta-analysis. What I will also wrap up with, I haven't listed here, what I will mention will be a short summary on some of the training opportunities that are out there currently for network meta-analysis, and also provide you with a short list of some tools you can use to help you appraise them as well. What William mentioned and what I'll reinforce here is I do want to make sure we get through the material today. So if you do have questions that come up during the session, what I'll ask you to do is try and keep a note of them to bring up at the end of the session. I'll answer as many as I can, and then for those we don't get to, I'll certainly invite any of you to contact me by email, and we can certainly continue the chat online that way. Now, before we get into the slides, I do want to allow just a minute for a survey, and I just want each of you to answer yes or no to the question here. Have you ever taken part in a systematic review that incorporated a network meta-analysis before? And I'll just let you guys vote for a moment. And we're getting answers very quickly, which is great. Still coming in. Based on what I'm seeing here, it looks like we're probably about 20% or so saying yes, you've been involved in one, but a very high proportion who have not. So that gives us a very good notion of our audience. Lots of folks who are interested in the topic, lots of folks who are looking for more exposure, and that's really what I'm trying to do with today's session. So with that in mind, I will move on and get started on the slides. So to begin, a brief reminder and overview about traditional pairwise meta-analysis, just to set the scene. And what I'd like to do is motivate this reminder, again, by thinking about an example. So I'll ask each of you to imagine you're a clinician. We've got a patient diagnosed with generalized anxiety disorder, which is a very challenging condition, cycles of anxiety, panic, depression, certainly a very challenging condition for patients to deal with. What you're considering recommending to them is treatment with one of two pharmacotherapies. One you're considering is an SSRI drug called paroxetine, and the other is another SSRI called sertraline. Now imagine the challenge you're facing is you have these two options to choose from, but you're not entirely clear on what the balance of each of these agents is in terms of the benefits it'll offer your patient to reduce symptoms versus the risk of having certain side effects which may also be problematic. So as a clinician, what you wonder is, I'm a bit unsure which way I should go in terms of prescribing treatment. Is there any evidence out there that can help me make this decision? So if we think about what might be useful evidence for us in informing this decision, I imagine probably a good number of you out there are familiar with what we call the hierarchy of evidence. And if we think about hierarchy of evidence, what that might tell us is if we can find a randomized control trial that's compared paroxetine versus sertraline in the right patient population, that might be our most unbiased source of evidence to try and decide which of these drugs offers a better risk-benefit profile. So we could certainly look for a published trial. Something else we might do to build upon that idea is expand on the notion of finding trials and do a more rigorous search of all the literature. Perhaps we might find all of the trials. So we can imagine we might have, for example, a set of 10 trials comparing paroxetine with sertraline. What we can then do with that information is a few more things. We can take a look across those 10 trials and see, do all 10 of these studies find the same response in terms of which agent offers a better balance of risks and benefits? We could also take a look, for example, at the response rate with each of the drugs in the trial and see, okay, well, if we're comparing the rate of patients in each study who are responding to treatment, do we see a similar number, a similar treatment effect across these studies? And again, if we're, for example, using a risk ratio to summarize the response rates in each treatment group across the studies, we could actually calculate an average treatment effect. We could take a weighted average across those 10 trials to get a notion of which drug is giving us more benefit and by how much. And with the greater number of patients and studies, we get more precision on our estimate as well. So these are very fundamental ideas. The idea of searching for all the relevant trials, I think many of you are fully aware of, is the idea of systematic reviews, finding all the relevant evidence, and then with meta-analysis, this idea of calculating a weighted average across studies. Something we are all very well familiar with is the idea of using these for evidence-based practice as well as to inform decision making. Again, a bit more background about traditional reviews. I think most of us are familiar with the general form of a research question that we use to structure a research question for systematic reviews, and it comes in what we call the PICO format, the population, intervention, comparator, and outcome. And it'll often look something like what you see in the yellow box here. So does treatment A produce better benefits than treatment B in some population of interest to us, which I called X? Drug A may often refer to the newer drug therapy. Perhaps it's motivating our review. We want to see how effective it is compared to other agents. B could very well be a current active standard available to us, but in the absence of an active standard, it might very well just be placebo or no treatment. We can certainly go back to our GAD example that I've mentioned, and we can frame the research question for that in our PICO format. And that's what I've broken down in the table below here. Our population could be patients with generalized anxiety disorder. Our treatment A and treatment B, or in other words, our intervention and comparator, are paroxetine and sertraline. And your outcome would be reduction of anxiety, for example, based on the Hamilton scale. And just to reinforce the idea of an average treatment effect for folks who are out there, what you're seeing here on the left-hand side, I'm suggesting that we have, for example, 5 studies that we found. So we have our first author name listed along with the year of publication. We have our forest plot, which is showing our summary treatment effect and confidence interval from each of the 5 studies, with the odds ratios comparing treatments on the right-hand side. If I move to the next slide, what I'm highlighting is the notion that with meta-analysis, we are combining those odds ratios from those 5 studies, and we're getting a summary odds ratio, which you can see as an average makes sense. It lies somewhat toward the middle of those 5 study level odds ratios, and it's also much more precise. So just a reminder of meta-analysis. But that's where I'm going to stop with just a very brief reminder about systematic reviews and meta-analysis. What I want to do is come back to the general structure of a research question that I mentioned just a moment ago. So again, we talked about treatment A versus treatment B. So something that's a very important limitation we sometimes encounter is the notion of how often does just talking about 2 treatments, for example, A versus B, how often does that truly give us an answer to a research question of interest? Now, the folks we have online today, you probably represent a fairly diverse amount of interest in different clinical fields. You can all probably think of many diagnoses where we don't just have a treatment A and a treatment B available. We may also have a treatment C, a treatment D, a treatment E, and so forth. So the idea is conditions that have many different treatment alternatives the clinician might consider. Now, if we think about just using the traditional pairwise approach in a circumstance like that, we have a challenge. The question is, how do we fit this question framework of A and B into answering a research question that also has a C, a D, and an E? Do we just pick a certain pair amongst the 5, 6, or 7 or more treatments? Do we look at all possible combinations and do a review for each? The challenge is, no matter how we slice it, it can represent a short-sighted view of the evidence. So examples of situations like the ones I'm talking about, and again, you can certainly think of many of interest to yourselves. The ones I'm citing here are ones that have been commonly studied with network approaches in the past. Rheumatoid arthritis is one example. We have biologic therapies we use, and I think this is a fairly complete list, but they do keep growing. Etanercept, infliximab, anakinra, abatacept, and so forth. Another one is smoking cessation. We have a variety of forms of pharmacotherapy such as varenicline, bupropion, nicotine replacement therapy in its many formats. And we also have a variety of types of behavioral therapy we can look at. And again, lots of other examples. Drugs for prevention of vascular events, pharmacotherapies that we use to treat depression, anti-fib agents used to minimize blood loss in cardiac surgery, and so forth. The point with all of these examples is if you think back to that A versus B framework, it doesn't really seem to fit what we're dealing with here. So the point I'm making is in circumstances like these, our A versus B approach really doesn't quite fit what we're trying to do, and we need to find ways to go beyond just two treatments. One more problem I will mention with our traditional pairwise approach. Something else that I think most or all of us may know is for a pharmaceutical product to get to the market, manufacturers are not necessarily required to perform a head-to-head trial against any current active interventions that are available for patients. It can suffice for them to do placebo-controlled trials, show a benefit of their treatment, show that there are no highly adverse safety risks, and that may suffice for their product to get to market. So from a systematic review perspective, we may say, well, we know there's a new treatment A out there. Let's do a systematic review of the trials, comparing it to active treatment B. But we may actually find that when we do a search for relevant trials, there may be none. We may have no data. So the only data we may be left with may be studies of treatment A versus placebo, studies of treatment B versus placebo. Now for folks who come from the technology assessment world, something that they are often told is from a decision-making perspective, we can't necessarily wait for the perfect evidence to emerge. We can't wait 3 or 4 years for someone to do the trial we're missing, or for someone to do a trial comparing 4 or 5 or 6 treatments. What we need to try and do in such a setting is make use of the information we have and see if we can come to a solution based on that information. And in this case, we're talking about trials of active treatments against some standard treatment, which may even be placebo. So then the question is, what sorts of techniques do we have to try and compare many treatments and to try and deal with situations where we may be missing key head-to-head comparisons? And the approach that was proposed some time ago was to try and employ these placebo-controlled studies or these standard control studies to derive something that we call indirect treatment comparisons. So the idea there is we may not have a study comparing A versus B, but under certain assumptions, which we'll talk about a little bit later, if we can consider placebo to be a sufficiently adequate adjoining treatment for us to compare A and B, with a little bit of mathematics, we can derive what we call indirect comparisons. And then network meta-analysis, as you'll see throughout the duration of today's presentation, is a technique where we can say, well, we do have placebo-controlled information. We also have some head-to-head information on the treatments of interest. And network meta-analysis will allow us to combine what we call direct information as well as indirect information. So it's a very advantageous technique, network meta-analysis, because it'll allow us, as you'll see in the example, not only to bring together direct and indirect information and to compare treatments missing head-to-head trials, we can also deal with a large number of comparators, which will allow us to answer more clinically relevant questions. I will just mention quickly here, some of you who have explored the literature may have seen different terminologies used. So terms you will also see associated with this technique include mixed treatment comparisons, multiple treatments meta-analysis, and I've already mentioned one related term, the indirect treatment comparison. So just a terminology note, and we've just mentioned it on the previous slide, but just to reinforce it. If we go back to our example for our patient with generalized anxiety disorder, we could consider a direct comparison that's meaningful to our question to be having at least one head-to-head trial comparing paroxetine versus sertraline. That sort of a study will be quite helpful to us for decision making. And we may have one study, we may have multiple. We also mentioned an indirect comparison. So the example here we talked about, you can now see on that horizontal line in the right-hand figure, I'm saying we have 0 randomized trials comparing paroxetine and sertraline, but what we do have are studies of each of those 2 drugs against placebo. And the goal is to compare paroxetine against sertraline using that indirect information. So that's a somewhat simple example, this triangular approach. What I'll ask you to do is keep that in mind, this concept of direct and indirect. And what we're going to do is look at a bigger network now from the 2011 BMJ paper. So here is the paper itself by Baldwin and colleagues. So treatments for generalized anxiety disorder. And what I'll draw your attention to is the lower right corner where you see a figure. It looks a little bit like a web, maybe some might say. This is what we call a network diagram. So what they did in formulating their research question was they looked to include all pharmacotherapies that they thought would be relevant and possibly used in practice to treat patients with generalized anxiety disorder. And then they set out to do a search to find all the relevant trials of those agents. Which you'll notice at the very bottom of that figure, placebo is also there, and that's there so that we can make use of indirect information. So just reading around that plot, you can see we have 9 treatments. We have escitalopram, duloxetine, fluoxetine, lorazepam, and so forth. What you're seeing on that figure, you see lots of lines joining pairs of treatments. What that's showing us is where we actually have discovered existing trials making those comparisons. So actual information that can go into our network. So for example, if you look at the line joining lorazepam to pregabalin, there's a number 2 on it. Then what that tells us is we have 2 trials making that comparison. So you can see how much evidence is included for some comparisons. The other thing you can see is we don't have any information for some comparisons. So for example, looking at lorazepam versus paroxetine, there is no adjoining line at the top of the figure there. So what that means is we do not have head-to-head data supporting that comparison. And what they often refer to this as, I've mentioned the term network diagram. You can also talk about this as being an exploration of the geometry of the network. The reason I am using this example, I will just mention this quickly for folks. For those who are going to continue on reading about networks in the near future, there's a paper by Ed Mills and colleagues published in JAMA from 2012. What it is, it's an overview of how to use network meta-analysis literature. So it's sort of a how-to-read article and how to appraise. They also make use of the Baldwin example. So in terms of continuity, it might be extremely helpful for folks to see the example once today, and then when they move on to that paper, be able to jump into something that's familiar. So here's the information that we have. What I'm going to do is recreate the network from this paper for you. So as I've mentioned, we have 9 agents that are included, which were judged clinically relevant and important to include in the network. So we can imagine having our librarian design a large search, and we do a lot of screening, and we find that the right trials that fit our network. So what I've shown you on the left-hand side is what I've called the body of indirect data. And I've called them indirect because those are all comparisons of the different agents against placebo, so they are not head-to-head trials. And you can see we have different numbers of trials for each comparison. We have 4 studies of escitalopram against placebo, 5 studies of duloxetine versus placebo, and so forth. You can read down that column. If you look on the right-hand side, we have what I've then called the body of direct data. It's a collection of all the head-to-head trials that were found. And again, you can see we have different numbers per comparison. We have 2 trials of escitalopram versus paroxetine, 1 trial of duloxetine versus venlafaxine, and so forth. We don't have data for every possible head-to-head comparison, but we have a subset thereof. So what I want to do is basically show you how this information maps into a network. you can imagine if you were taking a traditional pairwise approach to trying to compare all these treatments, you're dealing with a lot of reviews to look at and a lot of judgments to make based on the effects reported in each of those reviews. So I'm going to go through a series of slides trying to build up the network diagram that you saw on the intro to this example. So what I've laid out here, we've got all of the treatments. We have placebo at the bottom, and then we have each of our active comparisons mapped out in a circle along this slide. The first thing we're going to do is we're going to add in the data for just one of the pieces of indirect information. We have escitalopram against placebo. So you really can think of that as data coming from the search for a systematic review of escitalopram against placebo. And we had 4 trials there, so we can add that information first of all. If I progress the slide, we can add in the information now for duloxetine against placebo. I believe we may have had 5 trials there, I think, if I recall correctly. You can already think of a way we could perhaps indirectly compare duloxetine against escitalopram. Just here you can see we have that placebo as a common link. What I'm going to do is add in the rest of the indirect information. Now we had placebo-controlled trials for every comparison, every agent in the network. So you can see we have a joint from every active comparator to placebo when I bring in that entire body of data from the left-hand side of that earlier slide. Now what I mentioned as well before, when we have a mix of both indirect information and also direct information, we can synthesize all of that into our network and use it to derive our estimates of pairwise comparisons. So what I'll do first with this blue line, that's me adding in data for one of the pairwise comparisons we had information on. That's for escitalopram against paroxetine. Again, I haven't mentioned the number of studies, but I believe there was only 1 trial there. What I'm going to do on the next slide now is I'm going to map all of the direct information we had on our slide. So if I do that, what you now see is a series of blue lines. And what that's doing is highlighting all of the direct information we also had. So this should look very much like the figure we saw on the introductory slide for the example now, having laid out all the information we had from the included trials. The idea now is we also would like to get estimates for the comparisons we don't have data for. So on the next slide I'll bring up here, you can see a dashed red line joining fluoxetine to lorazepam. And you can see, for example, if you think about the triangle evident to fluoxetine to placebo and the placebo to lorazepam, you can see how we might derive an indirect comparison for those treatments using that as a common link. What network meta-analysis will actually allow us to do, if I move to the next slide, it'll actually allow us to estimate every possible pairwise comparison of treatments in our network. And that's what all of these dashed red lines show, comparisons where we don't have information, but using the indirect information we can estimate them. So what network meta-analysis, the crux of it is all about is the idea of synthesizing direct information and indirect information to try and generate a comprehensive set of all pairwise comparisons of the treatments in the network. And that's why this is so valuable. Instead of working through a long series of pairwise comparisons, we can actually perform a unified analysis to try and derive all of these estimates for further study. Now from a practical perspective, this is sometimes the challenging part of performing a network meta-analysis. There are different frameworks for performing these. There are Bayesian frameworks. There are frequentist approaches. Today's topic of conversation is not about those. But what I will say is, depending on the size of your network, data preparation can be challenging at times. Preparing your statistical model and testing it out. And then the running of the simulations as well. Now, assuming all of that goes well, what I'd like to do is just expose you quickly to some of the types of outputs you may see reported in network meta-analyses. So what you see here is an excerpt from the 2011 paper we're talking about. And my intention here is not to go into providing clinical interpretations of their findings. That's a separate conversation. Working through these can be a bit time consuming. But I want to familiarize you with what you're seeing here. This is something that is most commonly called a league table of all the pairwise comparisons. Sometimes it may be called the stepladder diagram. And what it does is it reports all of the possible pairwise comparisons between the agents included in the network. Now the examples they've provided in their paper, I believe there is not one reporting on the entire set of comparisons. What they have done is pursued an analysis in there where they've looked at the agents available for use in the UK and then taken a look at how those agents compare to all of the possible agents considered in the network. So in a case where we've run the network meta-analysis and generated estimates, we would next sit down, try to work through this table as we would a meta-analysis. We have summary odds ratios, we have credible intervals to work through and look at statistical significance, and we can try to get a flavor of what we're seeing in terms of what treatments offer us the best response rates based on the data from our meta-analyses. Here's an example of something else that you will also often see reported. So this is something else that is a bit novel to the reporting of network meta-analyses. We can also get an estimate of the probability that each of the treatments in our network might be the best treatment. So what you're seeing here, we actually have a bar graph. The Baldwin paper actually looks at 3 different outcomes, which you can see listed at the top of the figure. They look at treatment response, they look at remission, and they also look at a number of withdrawals due to adverse events. So what I've highlighted for you in the red square box, those are the estimates for fluoxetine. If we look at the y-axis, what you can see it's labeled as is the probability each treatment is ranked first. So what these seem to be telling us in this case is that for response, fluoxetine has about a 60% chance of being the best. The same for remission, and then it appears to be second best when we look at withdrawals. So you might think, okay, if I'm considering all of the outcomes, this one seems to be advantageous on several fronts based on the data that I'm looking at. We can also expand beyond looking at just the probability of being the best. We can look at the second best, the third best, and so forth. Something I'll come back to is the notion that using these rankings for ordering treatments is not always ideal. And I think that we'll discuss it on the next slide. So those are, just very briefly, those are some of the things you will see reported in these papers employing network meta-analysis methods. And certainly what I would say is ideal is to get repeated exposure to these things to improve your ability to interpret network meta-analyses, to become more comfortable with trying to see what the findings are that they generate. What I want to move to now is to talk a bit more generally about some of the benefits these techniques offer us. I think the one that is most clear to us, just having seen the example for generalized anxiety, is we can certainly answer much more clinically relevant questions. We talked earlier about how the traditional approach of comparing A versus B is very much sort of putting ourselves into a box in some situations. So this technique allows us to be more inclusive, and we can try to give clinicians more of the full picture in terms of what they might consider in their practice. Another valuable gain is that we can in fact improve the precision on our summary comparisons by considering all of the available evidence. If we think back to our sertraline versus paroxetine example, so just A versus B, maybe we only have one small trial comparing the 2 agents, but if we can supplement that with 10 studies of sertraline versus placebo and another 10 of paroxetine versus placebo, adding in those extra studies in patients will certainly give us more precision. The other one I'll mention, which is tied into the example we just saw, is there are some additional parameters that we can generate in network meta-analysis to help us try and rank the treatments from first to worst. As you can imagine, that's extremely attractive to clinicians and decision makers. The caution here, and in terms of research, it's really still being looked at. Without getting into the details of the simulation methods for network meta-analysis, there is some concern about how stable these probabilities may be in relation to the actual pairwise comparison estimates. So what's been recommended is that we do not use those in isolation of the pairwise comparisons. They're more of a supplemental measure to look at. And if you're interested in that particular topic, Ed Mills and colleagues have a nice paper in the BMJ published just last year. Just briefly, a little bit about uptake in terms of how many people are using network meta-analysis, and many of you may have already seen some of these numbers. I've borrowed one plot here from Georgia Salanti from her Cochrane Colloquium 2012 session. What you can see is just the number of published network meta-analyses that have been going on year by year through the 2000s, with a dramatic increase in the late 2000s, around 2008, 2009. And certainly if I had data for 2012 and 2013 here, you would still see this trend continuing. Again, I think many of us who have been at least exposed to this topic have seen that high-impact journals have been publishing these for quite some time now. The BMJ has published many. Lancet has published quite a few very large networks, JAMA, and the list can go on in terms of journals publishing these. Those who come from the realm of technology assessment know that many agencies around the world are now using network meta-analysis to try and address new agents and conditions that they're studying. Diabetes, obesity, rheumatoid arthritis, and so forth. Certainly the National Institute for Clinical Excellence has done a lot of wonderful work using network meta-analysis. I've spent time previously with the Canadian Agency for Drugs and Technologies in Health, and again, during my time there, we saw quite a few of opportunities to use NMA, and I think that's just increased for them since that time. Today's a Cochrane webinar, so I certainly need to also mention that Cochrane has a devoted methods group for dealing with multiple intervention reviews. The Comparing Multiple Interventions Methods group, and you can find their website at the link I've shown here, cmimg.cochrane.org. If you do go to that website, you'll find a lot of very useful things to look at. There's a lot of information giving background on what indirect comparisons and network meta-analysis is all about. Several folks there maintain a very comprehensive database about emerging methods publications, so if you'd like to be up to date on the most recent papers, it's a good place to look. Training opportunities, they keep a well-updated list of training opportunities, and I'll mention a few of those at the end of today's sessions. Something else that's quite neat to see there, they have a feasibility decision tree. So an actual decision tree where you can open it up, take a look at it, and if you have a research question you're interested in pursuing, you can go through their checklist items and see, okay, should I consider a network meta-analysis approach or not? And all the content here is wonderful. It's led by a lot of the experts in this field, Julian Higgins, Georgia Salanti, Debbie Caldwell, and other such folks. So one important summary statement I'd make is that network meta-analysis estimates comparisons which we might otherwise only be making in our minds. By bringing all the direct and indirect information together on all of the treatments we're interested in, we can do one unified analysis we can interpret rather than reading many reviews. So it certainly offers us many benefits in terms of interpretations. Theoretically, it can work with any number of comparators, and we see very different architectures. Though in practice, the broader we go, the greater the risk of introducing heterogeneity in terms of the studies. There are approximately 200 published examples of NMAs. I'm just going to very quickly show you 3 to show you some interesting geometries. Here's a 2009 Lancet paper looking at 12 antidepressants for treatment of depression. Data from more than 100 trials and 26,000 patients. So certainly an interesting read. Here's another very complex network. This was chemotherapy regimens for breast cancer, reported by Moher and colleagues in 2008. This particular network, 22 treatments, data from 150 trials and about 26,000 patients. And a more recent one, rheumatoid arthritis, and we've talked a bit about the treatments already. And again, data from about 37 trials and about 12,000 patients. And this is the most studied indication using a network meta-analytic approach. So that's lots of examples to try and motivate what a network looks like, how we can build them up, and a notion of how we can perform analyses and what we might see. What I would like to do now is spend just a few minutes talking about assumptions that underlie a network meta-analysis and what we need to think about in terms of meeting these assumptions to ensure we're producing a valid network. So for those who have read a bit about the background of network meta-analysis, you may have seen these terms: homogeneity, similarity, and consistency. These are the terms we most commonly talk about when we talk about assumptions we must meet. I'm just going to talk a little bit about each of the three of them in terms of how we might think about them in a network. The homogeneity, first of all. And if you think of our network, I said here we're looking at trials on the same comparison. So right now you can think about assessing homogeneity, for example, of just escitalopram versus placebo. We're going to look at homogeneity there. Going to the next branch in our network, we would be looking at duloxetine versus placebo. We look at homogeneity separately for each comparison in our network. So the concept of homogeneity, very similar to how we would look at homogeneity in a traditional review. What we would do, for example, if we have 4 trials, like we had for escitalopram versus placebo, we're going to look at the treatment effects across those 4 trials and see if we have relatively consistent treatment effects. So for example, we could look at I-squared measures as we commonly do. And what we might find is, for example, one of 2 things. If we look at the forest plots on the left-hand side here, we might find very consistent treatment effects like we see in the upper forest plot, or we might see very divergent treatment effects like we see in the bottom part. And what we're hoping to find certainly is the first example. And in terms of our network, as I've mentioned, we're going to look at this for each comparison in our network. So what we want to do is try and confirm that we have relatively homogeneous data for each of the links in our network. And if we don't, we have some exploring to do before we go forward with our network to try and sort out why that might not be present. Certainly also important to look at clinical homogeneity in terms of study characteristics, as we also commonly do. Similarity was the second assumption, and what this is now saying is not just looking within each individual comparison, but now looking across all comparisons within our network. So now, for example, going across the entire network for generalized anxiety disorder, can we say that the trials we're synthesizing are similar enough to each other to the point that we consider them to be what I would call combinable? So an example that's nice to look at here is just taking a subset of trials for rheumatoid arthritis. So you see 6 trials listed here. The control group in each of them is what we call DMARD therapy, the standard therapy. And then you'll see in the second column of this table we have 6 different treatments. So each trial is of a different treatment. Now, when we talk about looking at patient characteristics, we will commonly look at important characteristics measuring disease severity. I've highlighted the 3 here. Percent of patients on corticosteroids, disease duration, and disease activity. Now, I'm not a rheumatologist by any means. Some of you may be out there. The notion here is to say, okay, if I look at the characteristics of all these patients, do I feel comfortable saying that they should all be included in a network meta-analysis? Do I think that they are all drawn from a similar patient population? The study people will often draw most attention to is the FORCE study by Emory, where we see a very long disease duration, slightly different disease activity score. Some folks may argue those are to be handled separately. Now, my point here is not to say exactly which studies do and do not belong, but the point here is that we must consider very carefully the characteristics of our patients, the characteristics of our studies before we decide to perform a network meta-analysis. And again, this is very much like pairwise meta-analysis. It's just now a little bit more challenging as we get more and more treatments. And the last assumption was consistency. Now we know we're making many pairwise comparisons. We saw this with our GAD example. We've talked about having direct comparisons and indirect comparisons as well. So the premise here is to confirm that the messages or the clinical interpretations we get from direct and indirect information are relatively similar. If, for example, a head-to-head trial tells us that A beats B and the indirect comparison tells us that B beats A, we may have some exploring to do before we do a network meta-analysis and report it. So here's an example of this notion based on work by Fuji and Song. We can think about comparing bupropion versus nicotine replacement therapy for smoking cessation. So what I've shown you here is we have 9 placebo-controlled trials for bupropion and 19 for nicotine replacement. So the notion is we could compare these two treatments indirectly using placebo as our link. For the moment, we will imagine we don't have any head-to-head information. So we could do separate meta-analyses for each of the placebo-based comparisons, and we could then use those to indirectly compare bupropion with nicotine replacement therapy. If we do the mathematics, the indirect estimate suggests an odds ratio of about 0.9, and the credible interval suggests that there is no difference between these treatments. So it's an estimate which is relatively null. Now, if we do have a head-to-head trial, and the example I've shown here is that we do in fact have one. It has a summary estimate of 0.48 and is associated with a statistically significant credible interval. So this is suggesting a benefit here of bupropion. So in this case, we have relatively different conclusions and summary estimates. Jumping straight into a network meta-analysis here may not be a good idea. And there could be different explanations for this discrepancy. It could be random chance, it could be bias in some of the trials, it could be heterogeneity in the trials. Different options to explore. Consistency, we can explore it quantitatively. There are statistical routines for looking at consistency. Not unlike traditional systematic reviews and meta-analysis, our other two assumptions, homogeneity and similarity, require careful exploration of the study characteristics, the patient characteristics. Something very challenging with so many studies, as some of these networks do get quite large. But what I will reinforce, and we're only talking very briefly about these assumptions, they're absolutely crucial to establishing whether your network meta-analysis is giving valid findings or not. So it's extremely important to try and validate these assumptions in these works. Now, moving toward wrapping up, I just want to spend about 60 seconds on 3 topics just to point folks in the right direction for some future training opportunities or use of some tools. One is to talk about training, one is about computing, one is about reading. So in terms of training opportunities, there's a workshop being offered in July of this year at Oxford, and I believe this is a new workshop. It's a 3-day session on how to interpret, appraise, and also publish reports of network meta-analyses. I've given you the web link here. Being run by Georgia Salanti, Debbie Caldwell, and some other folks from Oxford. So I think that'll be a really interesting one. In terms of computing, how to implement and perform indirect comparisons in network meta-analyses. Now the first one I've mentioned here is very soon. It's next week in Switzerland, and I believe they are now full. So that may not be ideal, but I'll mention 2 more. One is this upcoming April in Leicester and Bristol. It's a 3-day workshop with Debbie Caldwell, Tony Addis, many of the folks from Leicester and Bristol, which is a wonderful workshop. One I was just made aware of, I'll mention as well, through the Canadian Agency for Drugs and Technologies in Health. They're offering a 3-day session in Toronto in February, at the end of the month. So while it's not listed here, you can certainly email me if you're interested. I can send you along to the proper contacts. I'll also just briefly mention there are 2 I'll be involved in as well in May at the CAVID Symposium and also at the Society for Clinical Trials meeting. For those who are looking for a bit about computing, I'll just mention quickly 2 references you can look to. The folks from Bristol and Leicester led by Sophia Dias. I've got a series of reports in the Medical Decision Making Journal, and also available through the NICE Decision Support Unit, which will take you through lots of the WinBugs programs available for performing network meta-analyses. Anna Kaimani, Jillian Higgins, Georgia Salanti, and others have also published a very recent paper talking about tools for Stata, tools to generate a lot of the graphics for networks in terms of network diagrams and some of the result summaries you can also generate for your reports. And lastly, just a few tools for those who are looking to appraise NMAs. This is by no means comprehensive, but we do have available through NICE a reviewer's checklist looking at reports of treatment efficacy and decision making. ISPOR, the International Society for Pharmacoeconomics and Outcomes Research, has 2 reports currently available to help readers in terms of interpreting network meta-analyses, understanding them, and they have a 3rd report coming out which will include a checklist for looking at relevance and credibility. I've mentioned the Mills paper already. I'll mention one more tool, which is something I'm currently coordinating as well. A group of us are developing a Prism extension statement for network meta-analysis. Without getting into all of the details on the slide here, I want to leave a bit of time for questions. You've got a bit of a notion from today's session that there are quite a few nuances to reporting a network meta-analysis which we don't see with pairwise meta-analyses. So that's why we're pursuing this extension statement. And we're making very good progress. We performed a systematic review of reporting issues, did a survey last year, and had a face-to-face meeting. We're currently in the writing stages, and hopefully we'll have it out for the summer of 2014. So I'm going to wrap up here. Summary conclusions very quickly. We've seen that NMA is a very useful and logical extension of pairwise meta-analysis. It allows us to get into indirectly comparing treatments and dealing with many treatments in situations where we need to. Very attractive to clinicians and decision makers because it can address very robust research questions dealing with the many treatments. What we also know is that there are many challenges given the increased amount of data. We need to make sure we can do a proper assessment of the assumptions for NMA. So with that in mind, we're very happy to be able to see so many tutorial articles in the literature, so many workshop opportunities that will help us improve our skills. We've only scratched the surface today in terms of what is a very rapidly evolving technique. So for those who are new to it, I hope this was helpful, and certainly I hope I can cross paths with some of you again in the future. So I will wrap up there. I'll turn it over to you now, William, in case there are questions or anything. It
looks like we do have a couple of questions. First of all, thank you very much, Brian, for the discussion today. Why don't we all send a round of applause that's under the smiley face for Brian. And then I'll read out the questions for Brian to see if he can answer. First one here is from Tatiana Shamilan. Can you adjust for patient characteristics and risk of bias in studies?
So that's a great question. So in adjusting for patient characteristics and risk of bias factors, you certainly can do this in network meta-analysis. A lot of it is very much like meta-regression that we see in a pairwise approach. We can include study-level characteristics. We can include aggregated characteristics of the patients like mean age, percentage of gender, and so forth. A lot of the same tools are available to us for heterogeneity. So the meta-regression you've asked about, doing subgroups on lower and higher quality as well. We can include and eliminate trials based on risk of bias. All of these same ideas do still apply.
Excellent. And before I take another question, I just want to encourage people to follow the link that I'm about to paste into the chat room. That will allow you to fill out the evaluation form. So here is another question. Tatiana had a couple, but I'm going to jump to another one. Do authors usually explain the methods they used to evaluate homogeneity, similarity, and consistency? If so, what are the usual tests performed, and what phrases should we look for to help us evaluate whether or not the analysis was appropriate?
So in terms of, just for the recording, do they report methods of how they evaluate the assumptions of homogeneity, similarity, consistency? The reporting is certainly improving. Without recalling the specific numbers we've seen recently, papers are getting better and better at mentioning their statistical efforts to look at consistency in networks. Homogeneity and similarity, it's a little bit like pairwise reviews again. It's something we know we need to explore characteristics of the studies closely and carefully. I don't think it's always made as explicit as it should be in either kind of review to say specifically what we looked at to make those judgments. I think quite often, even in traditional reviews, different folks may consider homogeneity to be at different levels, and transparently reporting that is something that I don't think is done well enough in many reviews right now.
All right, thank you. Here's a question from Mags Watson. Has network meta-analysis been applied to non-pharmacological treatments, for example, behavior change techniques?
It definitely has been used in looking at things beyond the realm of drugs. I've seen a number of published examples. Of course, in the context of right now, I'm not going to be specific of those. We've seen some for surgical techniques. I believe I've seen a few dealing with behavioral therapies, but the clinical area I'm not recalling now. But I certainly welcome emails, and I can help locate those afterward.
Thank you. Here's a question from Julia Bidon. Please speak of the main differences with findings of an umbrella review.
That's a wonderful question, and what I will say honestly is I have not been tied in enough to the terminology differences with an umbrella review. I've seen it mentioned in spots, and it might in fact be extremely close in terms of bringing even what we're talking about together, actually doing a network meta-analysis. I don't want to claim to have worked on an umbrella and know whether there are very large differences or if they're very close. Again, I would suggest a follow-up to me.
Hi, this is Erin Easy with the Canadian Cochrane Centre. I'd just like to let folks know that we do have a webinar on umbrella reviews, or what in Cochrane we call overviews of reviews. You can find the link has gone through the chat room a couple of times to our archives. So we just had a webinar in December on umbrella reviews. So please do take a look at that.
All right, here's a question from Samuel Schumacher. Have network meta-analyses been done for diagnostic accuracy, such as outcome, comparing multiple diagnostic tests?
If it has been done, I have not encountered it in my exposure to all the literature. So while I can't guarantee it has not been done, it's certainly not something that I've seen yet.
Another question about tools. Is Cochrane working on development of software similar to RevMan that would facilitate computational aspects of network meta-analysis?
I'm not familiar with any efforts of Cochrane to generate software for it. Part of the reason maybe, again, that it's a technique where involving a statistician is ideal because of some of the issues in running simulations. There are more software packages evolving, and one of the ones which is somewhat RevMan-like in its design is a software called ADIS. So for folks who are interested, if you Google, I believe it's spelled ADIS, you can actually download that, and I believe it runs Bayesian methods in the background. I know it's been going through pilot testing, and it might now be a final product, but I'm not positive. I have not had a chance to explore it very much yet.
Here's a question from Ahmed Ajula, approximately. Is it recommended to conduct a Bayesian MTC for open loop or star-shaped networks? He's heard that only closed loop networks should be considered for Bayesian MTC.
I think one of the challenges, and it's something I'm still wrestling with in more conversations with folks, some will say you cannot properly conduct a network meta-analysis when you don't have closed loops. I think a challenge to all of these, which is still being wrestled with by a lot of folks, is you can always generate numbers from network meta-analysis, but it's what strength of interpretation we should have in terms of relation to the geometry. So for example, when we have statistically significant findings for example, A versus C, but we're in the absence of any head-to-head information, how strongly we should interpret those findings is something that is still a challenge, and it's still a topic of discussion in the literature from a critical appraisal perspective and from a decision-making perspective. So I think you can always run the numbers in these different geometries, but I think having the right overlay on interpretation is the challenge.
We have another question. What would you say are the weaknesses or major criticisms of network meta-analyses today?
The one that comes up the most often, and I've encountered with a lot of clinicians, is that folks consider it to be a bit of a black box technique. The statistical modeling for it is quite a bit more beyond what folks are used to thinking about from a pairwise approach. So a lot of folks, because they don't quite know what's going on, believe it to be a challenge to buy into quite as much. I think one of the big weaknesses right now is it's also very attractive because you can crunch a lot of data into one analysis and get all these comparisons back. And when it's such a number crunching exercise, there is a tendency by folks to skip by the part of thinking about the assumptions. They may not think about the homogeneity of the study so much. They just want to get to those summary estimates. So I think that's a bit of a risk in terms of ensuring we always have valid findings that are reported.
It looks like the questions are slowing down, but we've got one last one. Is there a minimum number of comparators needed for network meta-analysis to ensure that results are valid?
I mean, you can use it with as few as 3 comparators, so I would say that would be the minimum number you'd look at. You know, if you're looking at one of these simple triangles, and you can certainly expand out from there. Fitting the models can be a challenge when you only have one trial per comparison. Some of the fits are a bit more challenging to make work, but it can be done. But certainly the notion of having multiple trials for the different comparisons and so forth is advantageous.
All right. Well, thank you very much. Thanks everyone for your participation and time, and thank you to Brian Hutton for speaking. That'll be the end of our Cochrane webinar for today.